Welcome, everyone, to another episode of Aquarian Insights. And today I'm so happy and delighted to have Dr. Carol McMakin with me today. And Dr. McMakin is the pioneer behind Frequency Specific Microcurrent, a technology that she resurfaced from the early 1900s in the mid-90s. And with her ingenuity and sharp clinical mind, to me, she has created a system of thinking and application of frequency technology with clinically proven use cases and shown time and time again just how effective FSM can be. And in the process has changed the lives of thousands of patients and practitioners. To me, she has written the book on treatment of pain disorders that all practitioners need to read if they haven't already, and has also written a wonderful book called The Resonance Effect that everyone should get their hands on. And I'm forever thankful for Dr. McMakin because FSM, to me, has made the seemingly impossible possible. So thank you very much for being here today.
You're very welcome. That is the best introduction I've ever had.
Well, thank you.
I'm so honored and so pleased that FSM has done that for you and your patients. This is awesome.
Yeah, it's so exciting, and it's a really funny thing. I think with my personal journey with it, I had a mentor of mine come to me. This would have been early 2000s when you were just getting started, and showed me, and I said, that makes a lot of sense. I couldn't wrap my head around it at the time. And I was like, okay, we'll wait. And I waited, got to a course finally. And as soon as I sat down and started listening to you talk, I said, why didn't I do this before? This makes, and I think a lot of folks have the same experience. But I wanted to start today a little bit of sort of how you started developing this technology. And I think the biggest thing now, because when you started, there wasn't much sort of energy medicine or frequency medicine or anything. You were definitely a pioneer in that regard. And now there's so many devices and so many things that are direct to consumer or market. I think for a lot of folks, it's hard to delineate what's what.
Yeah.
And being a clinician, I've tried all the gadgets and the doodads and everything. And at the end of the day, I always come back to FSM because it works, and it
Yeah.
works better than anything else that I've tried.
Oh,
So maybe we can start there a little bit in sort of what separates kind of FSM from some of the other devices or what's involved with the technology.
oh, that's a wonderful question. It started really simply. I had been taught manual trigger point therapy, and I was working on this patient's gastroc, a trigger point in her gastroc, and she came in with a pain at a 2 or a 3, and as the knot disappeared, her pain went from a 3 to a 7. Now, I knew George Douglas at the time, and I called him and I explained the situation, and he said, there is a blue microcurrent machine in room 2. Go and get that, set it up so that the 2 channels cross in the area that you've worked on, and put 18 hertz on channel A and 62 hertz on channel B. And I said, what's that for? And he said, well, I'll tell you if it works. So I did what he said. He was one of my instructors at school. He was always also my partner. And so I did what he said. And sure enough, the pain went from 7 to a 0. And I called him back and I said, okay, what did I just do? And he said, well, 18 hertz is the frequency to stop hemorrhage, and 62 hertz is the frequency for the artery. I said, what frequency? The frequency is from the list. What list? The list I got from Harry. Can you expand? Harry Van Gelder was exactly. Harry Van Gelder was an osteopath and naturopath from England and Australia who came to the US and Canada in 1946, bought a practice, and went through the practice. And in the back room, pulled a sheet off of this old machine. And he thought, well, that's interesting. And under the machine was a list of frequencies. As it turns out, the machine was made in 1922. And the history of it is that frequency medicine was used from the early 1900s up through about 1925. 1910, the Flexner report came out, and the Flexner report says there's too many medical schools, there's too many Black physicians, and drugs and drug companies were just now being formalized, and all of that has to stop. So drugs and surgery are the only allowed tools of medicine. And that was 1910. And by 1923, 24, they started getting serious about it, prosecuting practitioners, putting them in jail, shutting people down. And so the machines either went on the junk heap or went in the back room and got covered up in a sheet. So that's 1925 to 35, that period. Well, Harry walks in 11 years later and says, what's this? He's from England. He doesn't know the politics. So he takes the list, and the way the list works, there's the frequencies for conditions. Inflammation is 40 hertz. We assumed it was to reduce inflammation, not enhance it. Scar tissue is 13 hertz. And then there's a whole list of tissue: fascia, connective tissue, nerves, arteries, capillaries, small bowel, large bowel, adipose, you name it, there's a frequency for it, almost everything. So we went from 18 and 62 to using it in practice together. So I graduated from chiropractic college in 93, got my license in 94, started working in a practice. And in 95, I started teaching a continuing ed course at Portland State University and became Portland's resident expert on fibromyalgia patients. So we got more and more difficult patients. And I only worked Monday, Wednesday, Friday because I had 2 kids. And George said, well, why don't we work Tuesday and Thursday morning and work together? So I go, okay. So he knew Harry's ideas about how the frequencies worked, what caused what in what tissue. And he would dowse for or test for what frequencies would be appropriate. I did the manual work. That was through 95. 96, I started treating patients on my own, mostly for muscle pain. And the results were impossible. So a neck that felt like plywood, I used the frequency for hardening in the fascia and the muscle belly. And this patient's neck turned to pudding. And it's like, okay, that's not possible. And so 96, we treated 100, 150 or so patients. 97, I had to teach it to find out if it was reproducible. Okay, is this real? Or is it a placebo? Is it because the walls are pink and I'm a nice guy? Right. And so I taught it in January of 97 very badly. It was really awful by today's standards. And by June of 97, the reports had come back. There were 10 people that bought machines from Doug Casey. And by June of 97, I knew it was reproducible. So if they did what they were supposed to do, they could do what we did. So 98, I figured out how to treat nerve pain. How do you do that? Well, you look up in the medical literature. What is involved in nerve pain? All the studies on nerve pain involve either arachidonic acid, inflammation, or stricture. Well, inflammation. I have a frequency for inflammation. So what is nerve pain? Inflammation in the nerve. So 98, we figured out how to treat nerve pain. 99, I treated fibromyalgia caused by spine trauma. And the only thing that would cause full body pain was inflammation in the spinal cord, because that's where the pain pathways go up. And there were 27 patients. And one of the people I had met along the way was a PM&R doctor whose job it was that year to pick the speakers for grand rounds at NIH. And I presented these cases of fibromyalgia from spine trauma at a meeting in England, and then came home, and there was this meeting at NIH, and I presented the cases, and I said, look, I have done this 27 times. It never fails if they meet these criteria. So these are the inclusionary criteria. They come in with their pain at an average of a 7.3. They leave with their pain at an average of a 1.3, and they are recovered from fibromyalgia in 4 months. That's the data. And no one is going to believe it unless you guys, with the white coats and the crossed arms and the pocket protectors and the glasses, tell me, somebody has got to tell me objectively what's changing. So Terry Phillips came up. He's a microimmunochemist. And he said, you need to send me blood spots on blotter paper. Okay. So he sent me the blotter paper, and I called a patient we hadn't been able to help. And I said, well, I'm going to have to prick your finger. She said, it's just fine. So pricked her finger, took a blood spot, put the time on, pricked the finger, turned the blood spot. And they weren't at regular time intervals. They were when things changed. So out of that, the next stop was Jeff Bland's IFM symposium, his international symposium. So I went through the same slides I went at NIH, but I added Terry Phillips' cytokine data. And so I had a room that had originally been set for 40 people, and then they moved me to a room for 80. Then they moved me to a room for 225. So there are 250 people in the room. And I saved time at the end to go pounding through the cytokine data. And what happens with the cytokines is impossible. Interleukin 1, which is the one I remember, went from 392 down to 27 in 90 minutes.
Wow.
So I had walked into the hotel, and I saw Jeff. And he's the one that started IFM, functional medicine as we know it. And I said, hey, Jeff, I got this data from NIH. And I said, yeah, let me see. And he took the paper and he looked at the graph, and his hands started shaking. And that's when I knew. And I said, this is fine, but I don't know what these mean. Is it no big deal to go from 400 to 27? And he said, you should call Michael Ruff. It's noon here. He's still in his office. Give him a call. He and Candace Pert wrote The Molecules of Behavior or The Molecules of Emotion. And he is the national expert on cytokines. Call Dr. Ruff. And he said, yeah, I said, Dr. McMakin, Dr. Bland said to call you. I'm Dr. McMakin. He said, yeah, what's the data? And I said, well, there's fibromyalgia from spine trauma. And interleukin 1 goes from 392 down to 27. And it's like the line went dead. Hello? And his voice was a little whispery when he came back and he said, what time frame? I said 90 minutes. Now you have to remember, in 2000, there was no Google. There's no place to look this up. There's no medical library at Saddleback Hotel in Phoenix. And he said, what time frame? I said 90 minutes. And the line went dead again. And I said, Dr. Ruff? And he said, that's not possible. Cytokines are hard to change, and when they change slowly. And being me, I was very perky when I said, no, they're not. They all change like that. And he said, what do you mean? I said, well, TNF alpha, once again, went down by 20 times. Interferon gamma, interleukin 6, interleukin 8, all went down at logarithmic rates by 10 and 20 times in 90 minutes. Endorphins go up. VIP goes up. Substance P goes down. Substance P is the neuropeptide that conveys pain. And he said, how did you do this? I said, with frequency. Reduce inflammation in the spinal cord. Who did your data? Terry Phillips. He said, well, Terry Phillips is the one that does our data. He's the best in the world, so that's not it. Let me know what happens. So then when I presented these slides, the room was electric. I pounded through 32 slides at the end at about 4 seconds a slide. And you could tell the people that knew something about cytokines because their jaws dropped.
Yeah.
And that's really the only hard scientific data we have. It took us 5 years to get the paper published because the medical community did not want to hear that fibromyalgia was curable. Right. So the first 4 times we tried to publish the paper, it was titled Resolution of Fibromyalgia Associated with Spine Trauma. The 5th time, we called it Cytokine Data with Treatment of Fibromyalgia Associated with Spine Trauma. Leon Chatow published it in JPMT, and that was the beginning. So Metagenics picked us up. We went national in 2003. I was lecturing at that point in Australia, also in Ireland, and it's just been from there on. And every day you see a patient that is impossible. It's just impossible. Yeah. So there's a frequency for scar tissue. And you put your hand on somebody's belly. So we did one study that's never been published, but we did this one study first in rats and then in 8 women who had pelvic pain, abdominal adhesions. And you run scarring in the small intestine. It's usually endometriosis, IBS, Crohn's, something that's created inflammation that creates scar tissue. So you use the frequency for scarring in connective tissue, and that releases the scarring between the intestine and the peritoneum. It's kind of like what the scar is made of, is scarred connective tissue. Then you go into the small bowel and you find a tight spot. You run scarring in the small intestine. It softens by 2 millimeters, and then you just stretch it. And in the rat, it liquefied. You started out with something hard and white, you run scarring in the connective tissue, and it turns clear and it turns to snot. And then you do that all through the abdomen. You treat for inflammation. And this last year in Taiwan, we had an ultrasound of a woman with severe pelvic and abdominal pain from surgeries and endometriosis. We did a Doppler. It was all red. You could see scar tissue in the layers of fascia, the ovarian tubes. And at the end of 45 minutes, we redid the ultrasound. The Doppler was all blue, and you could see where the scar tissue had disappeared in the ovarian tubes. And that's where we are now. It's so incredibly surprising every time. You never go to work. You go to play, and it's incredibly rewarding to have somebody where you give them their life back, you know?
Yeah, and that's been, there's very few things that I've encountered clinically where someone can come in and they've been told by other physicians or whomever that they have no chance and they just have to accept their fate, sort of.
That's my
And
favorite one.
yeah, and then you get them, and then 90 minutes to 2 hours later, they walk out of your office a completely new person. And
Yeah.
that is the most incredible gift that and it's not me doing it, it's the understanding of all of these things, but it's such an incredible, amazing gift. And I think for me, because I have an interesting practice in that I'm seeing professional athletes, but then I'm also seeing chronic complex autoimmune conditions.
Me too.
Yeah, and it's the same as you, right? Because on both sides of it, FSM is sort of central to any sort of treatment program, and it's just been such a wonderful, wonderful gift to have this available tool.
Yeah.
And I go
You
ahead,
have
sorry.
to give yourself credit, though, to be able to use FSM. It took me 15 years. Now I've been teaching it for 30. It took me 15 years to figure out that my goal was not to teach people frequencies. You can look them up. I don't want you to memorize them, which of course made it easier for people to memorize them. My goal was to teach you to think. When you have frequencies as a tool, the first thing you have to do is disbelieve the diagnosis. You have supraspinatus bursitis. Yes. And where did it come from? Why do they have it? Well, it's because their subscapular nerve is glued to the subscapularis muscle. What? Well, yeah, it's an internal rotator adductor, which weakens the external rotators and the abductors, and it prevents, it inhibits, the brain inhibits the muscles that depress the shoulder. So when they do this, it squashes the bursa and the tendon. So is there any way to fix supraspinatus, tendonitis, bursitis without taking apart their armpit first? No. And this is how you take apart their armpit. It's scarring in the nerve. Scarring in the nerve to fix the bursa can't be done otherwise. So you take apart their armpit, and all of a sudden, what appeared to be weak, external rotators and abductors, doesn't take 30 minutes. And their brain says, oh, okay, now it's safe. And they end up with their arm over their shoulder and no pain. And you spend maybe 5 minutes treating the bursa and the tendon. But
Right.
giving yourself credit, you had to understand the logic, recognize the problem, and use the right frequencies. You can treat inflammation in the bursa all you want. It's not going to change until you treat the armpit. And you did that. That's
Yeah.
extraordinary.
Yeah. And I mean, I was taught very well, so thank you. And I think that's one of the most beautiful things with this, with like other devices and other things, is without a clinical understanding and a clinical education of sort of how the body works and how we can use these things to our advantage, it doesn't mean much to me. And that's why the evolution of the education and your commitment to like making it better every year, like if as a clinician, if you miss a year and you go back 2 years later, you're like, holy smokes, what did I miss in the last 2 years?
Well, Kim would say, I'm sorry, and you're welcome.
Right. Yeah, yeah,
Yeah,
absolutely.
it
And
changes every time.
yeah.
I mean, the basics are the same, the numbers are the same, but the way you think about it and what we learn every year is just extraordinary.
It's extraordinary. And one of the things, kind of to your fibromyalgia point and sort of the genesis of this, is one of the beautiful things with FSM for me has been the neurological disorders or things that have been untreatable from a physician perspective, because it's hard to treat these things with pharmaceuticals or surgery. And so folks are just left in this no man's land. And maybe you can talk a little bit about just the role in CRPS in fibromyalgia and how FSM can deal with sort of the central sensitization component to pain, because I think that's something that everyone has to deal with at some point, regardless of what the injury is or what the condition is. And I've just seen FSM be such a wonderful tool in that regard.
That's the most fun. So it was an accident. Um, I had, as a practitioner, an MD from Mayo Clinic whose specialty was dysautonomia or CRPS. And she explained what CRPS really is. It is the sympathetics and the peripheral nerves being injured or inflamed by some peripheral injury. So the patient gets CRPS when a beam drops on their foot, or they have a cast on that's too tight, or they get an injection, or something happens that inflames the periphery. And in a particular kind of patient, the nerves simply disconnect. They're still there, but they're neurotransmitter neurologically disconnected.
Mhm.
The nerve is inflamed. So the first thing we run is inflammation in the nerve. And there's a video, if you Google CRPS or RSD and frequency specific microcurrent, you see me treating my son. And he had CRPS for 13 years, and it affected a cutaneous nerve because he had surgery. Now, the knee is a spider web of nerves. It's amazing any patient ever has surgery on a knee that doesn't result in nerve pain. Well, they put the cast on and put him in a boot, and within a month, which is pretty normal, he had exquisite hyperesthesia on his knee in the cutaneous branch of one of the nerves that went from just above his knee down onto the lateral calf. And he had winter and summer, he wore basketball shorts. Being a 28, 29-year-old guy, he never asked me to work on him, even though he knew what I did. And then one day, one of my staff quit, and I said, hey, are you busy this weekend? No. Well, he worked for the device company, Precision Distributing, and he did the tech support for PDI. And I said, are you working this weekend? Are you busy this weekend? No. He said, well, I need you to work the seminar, because she gave us literally 2 hours notice before she quit on the night before the seminar. So he came to the seminar, worked the seminar 2 days. Saturday morning, he came in looking kind of gray. I said, what happened? He said, oh, I got into gluten last night, and it always sets off the CRPS. It's really bad. I'm about a 7. I said, great. We've got our videographer here, and we're going to get you on film. So you take an area, CRPS, for those that don't know it, soft touch on the skin is exquisitely painful. Taking a shower hurts like crazy. The pain is constant. It only gets worse when you touch it. The light touch of cloth is excruciating. So they sleep without a sheet on their leg. And it's usually in a periphery, although we did have a couple of cases where it was central in the gut. And following Catherine's directions, you go from above where the nerve starts. This particular nerve was part of L3. So I put one contact where the nerve starts, the other contact at the end of the nerve. And the exam, he was covered with felt marks, felt pen marks, marked the whole area. It was about this big. And then after 20 minutes, it had gone down by 2 inches. After 30 minutes, it went down by that much. Took about 45 minutes to be that big. Once the hypersensitivity goes down to that big, pain is almost gone. You have to run the frequencies to, now you've run 40, which is to reduce inflammation. Then you have to visualize the receptors on the nerve, on the tissue that the nerve corrects to. So you have these receptors waiting. When the nerve disconnects, the science, the papers show that hundreds of receptors show up within minutes, waiting for one drop of a neurotransmitter, one drop, acetylcholine, dopamine, one drop. So you run increased secretions in the nerve, and the receptor grabs it. Now you're alternating reduce inflammation in the nerve, reduce inflammation in the sympathetics. Then you increase secretions in the sympathetics only when it's a small increase secretions in the nerve. And then it's just a matter, and we learned this by doing it wrong for years. I had one patient that taught me. Then you have to connect the periphery to the brain. The cerebellum has not heard from this nerve for 13 years. So we use the frequency 81 hertz and increase secretions in the cerebellum 84 hertz. And it worked. The patient before him all of a sudden went from not being able to use her legs to like she didn't know where her leg was in space. No movement, no motor activity. His leg was fasciculating. We ran increased secretions in the cerebellum. Bam, the leg worked. Then all of the information from the leg shows up in the thalamus, the pain centers in the midbrain, but it stops there. So you reduce the activity of the midbrain to get it out of the way. And then we use the frequencies to increase secretions in the sensory and motor cortex. Your sensory motor cortex connects the brain to the periphery so you know where your shoulder is. That is the purpose of the sensory motor cortex simplified. So we ran increased secretions in the sensory motor cortex. That's the point at which he looked up at the lights and said, did those lights just change color? So then we ran 40 and 89, which is quiet the activity of the thalamus. And that's where central sensitization comes from, is the thalamus. So patients who've been in pain a long time, the only representation for that limb stopped in the thalamus. So we quieted the activity in the thalamus, and that's the point at which he started crying, was when the pain went away for the first time in 13 years. Then we had to teach him to walk again. So watching that on video, my son passed away in 22. George Douglas passed away in 22. So having on video this RSD and frequency specific microcurrent, watching us teach Adam to walk again, watching the muscles work, watching George watch over him. It's one of my favorite videos, mostly because it shows how we did it. And you have these felt marks on his leg that just go down. And we just happen to have our videographer there. So central sensitization happens in the spinal cord. We have Jay Shaw come from NIH once every 3 or 4 years. And he talks about and shows the pathways and the chemistry that allow any kind of peripheral pain to be sensitized to rise in the spinal cord more easily than it would have before, and sensitized in the midbrain. The pain, you know that you have some pain that hurts. If you actually looked at it, it hurts like a 3 or 4, but it bothers you an 8. It drives you absolutely nuts. That's usually nerve pain. And that is the thalamus telling you, this is dangerous, we are going to die. This is a very primitive part of the brain. You're an animal on the savannah, and unless this goes away, you're going to get eaten by a hyena. So it's that amount of gripping, because the thalamus, the hypothalamus, and the amygdala are all very close together. And the ability to manipulate that, when we have multiple machines now, I have one machine that is only programmed for quieting the thalamus. There's another one, a little custom care for quieting the spinal cord. There's a third one for doing what I want to do on the periphery. And there's a fourth one that runs what we call the concussion protocol to quiet the medulla and turn on the vagus. Because once all the peripheral pain is gone, the vagus has to be turned back on so that the vagus will tell the thalamus, hey, it's okay. We're fine down here. So that's how it all evolved, was from those patients. In the resonance effect, there was a patient that arrived on a Monday. She had CRPS and fibromyalgia. Fibromyalgia was gone by Wednesday. No, the CRPS was gone by Wednesday. The fibromyalgia was gone by Friday. She spent the weekend getting herself off of all of her opiates. And when she came back Monday, all she had was L3-4 and L4-5 facet syndrome, and I called an MD who did my injection therapies, and he could see her on Friday. So I put her in the pool at the place she was staying. I sent her to physical therapy. We did FSM on her every day. And by Friday, she got her injections. When she left 2 weeks later, she left 2 weeks later, she no longer had fibromyalgia. She no longer had CPS, and it was permanent. 7,
Yeah.
8, 10, 12 years later, it's still permanent.
And that's the biggest thing when we sort of take your lead on this as clinicians and work through these neurological problems. A lot of folks will say, okay, you know, it'll come back or whatever, and it doesn't. If you go through the steps properly and sort of rewire everything properly, it doesn't come back, and that is such a incredible gift.
Yeah.
It's mind-blowing, to be honest. But
Yeah. And every time I do it, that's the thing that makes it the most fun. If it comes back, it's because you missed something, and it's like, yeah, that's okay. If it worked yesterday, it'll work today. Let's just figure it out.
Yeah.
And the patient goes, oh, it doesn't bother you that it came back? No, of course it came back. We'll just fix it. That's all right. And that is the most rewarding part, is that for an awful lot of people, the missing piece was the neurologic part, was treating the vagus,
yes.
getting rid of the scar tissue, treating scar tissue in the vagus, in the abdomen. We had a patient with CRPS in her belly. I'd never had one, and it centralized to her whole body. So we got rid of the central sensitization, but her belly, when she urinated, it felt like she was urinating shards of glass. Digesting food was exquisitely painful. She was only 19. She'd had it since she was 6.
Wow.
And treated her for 90 minutes. And there were 4 of us, 3 MDs and a nurse. And we sat down the night before we were going to treat her for the first time and said, this doesn't make any sense. And one of them said, what if the vagus was a nociceptor? Nociceptor is a pain nerve.
Mm-hmm.
Well, then it would be like CRPS with the vagus that's disconnected. So she had gastroparesis, her gut didn't work. But the vagus is a pain nerve. If you have gas pains in your belly, it's because of the vagus. So we did that. Treated increased secretions in the vagus and vitality in the vagus for 90 minutes. And then one of the practitioners is an MD from pain specialist from someplace, sat there and took the adhesions out of the vagus in her abdomen, because she'd had a feeding tube and she had endometriosis, and her vagus was just scarred. It's like a spider web in our belly. So she treated scar tissue in the vagus. We reconnected the vagus to its periphery. She got up off the table. Her POTS was gone, which is untreatable medically. Yeah. The POTS was gone. The pain was gone. She went to the restroom and came back with this shocked look on her face. And she said, it didn't hurt. And it was permanent. Yeah. There are no words.
No.
When you start from scratch. And, you know, when I lecture on this stuff, it sounds like it was obvious. But the truth of the matter is, you just kind of work from first principles and try stuff, right?
Yeah. And that's I remember years ago you said something to the effect of efficacy first and mechanisms later.
Yeah.
And that's, as a clinician, I'm just I'm all about function. So
Yeah.
what functionally can I improve, and are we making change, and is it a positive change, and does it last? And then we can kind of reverse engineer why, so we can intellectualize it a little bit. But I think that's just such an important thing, is this tool allows us to try multiple things very quickly and run through succession of conceptually what we think is sort of the most pertinent thing. And if it doesn't, if the frequency is not the right one, it's just not going to work. And and like you said, that's okay. That just means we miss something and we just go on to the next one. Um, but I think the work that you've done around the Vegas in the last couple of years has been so incredible. And one of the things that you said a while ago is just asking the question, like, what turned the Vegas off? Because there's so many devices and other things like vagal nerve stimulators, or there's exercises or whatever, but it's never going to lead to complete resolution because we haven't figured out what turned it off. And FSM, once we figure out what turned it off, FSM can be the tool to turn it back on again. And I think that's just such a beautiful thing.
It was such a game changer. So many, when you look at long COVID,
Yeah.
so many symptoms of long COVID that it just drives people crazy. It shows up all sorts of places. Every single case of long COVID that I've treated, aside from smell is different. There's 6 viruses that showed up. 1915, there was an epidemic. 1917, there was an epidemic. 1919, there was a pandemic. So by 1922, they had developed these 6 frequencies for viruses. So I just ran in 2020. I just made it up. I just did 6 viruses with the arteries, the capillaries, the heart, the liver, the kidneys, the lungs. And then the next month, they found out that the brain was getting hit. So we threw that in. Now it's those 6 viruses in the vagus. The vagus is turned off or down. It's never completely off. It's turned down by infection, stress, and trauma. So your history changes as a clinician. Okay, so you started having gastroparesis in 2020. What happened in 2019?
Yeah.
Nothing? No, there's something. What happened in 2019? Well, I got COVID 3 times. Yeah, that would count. So you run the frequencies for the viruses in the vagus, then the frequencies for the virus in the small intestine. It's very well vascularized. And the viruses hit the ACE2 receptors in the blood vessels. So virus in the kidneys, virus in the small bowel, virus in the vagus, reboot the vagus. And you keep doing that, reboot different parts of the brain, reboot the thalamus, right? Use the viruses in the thalamus. Why? It didn't occur to me until I figured out that using the viruses in the vagus wasn't holding. It wouldn't work.
Yeah.
Okay, what turns the vagus off? Oh, the thalamus. Okay, well, you do that. We did virus in the thalamus, virus in the vagus, virus in the small bowel, the liver, the kidneys, and she settled right down. It's been extraordinary to be able to treat that from a thought experiment, and then finding out that in a clinical setting it works. You can't call anything COVID, so we just call it flu viruses. Okay.
Right. Yeah, and that just, I think the last couple of years especially, it just has reinforced to me how powerful the tool is, because as we were all trying to figure out how to help folks that had dealt with the acute condition or sort of the longer forms of it, FSM has been a very powerful tool for me and many, many other folks, because we can try things. I mean, it's with pharmaceuticals, there's a cost, and same with a lot of natural remedies too. And the time course to see a change can be days, weeks, whatever. It can take a while. With FSM, we can just implement it right away, and we know within 20 minutes if we're on the right track or not.
Isn't that
And
fun?
it is fun. Yeah.
It's like instant gratification.
Yeah.
Yeah. When I tell people that take FSM, I did a video once and I just started laughing. I said, you should take an FSM course because FSM is the most fun you will ever have in medicine. And that was the closing line. It just, I love going to work every day,
Yeah.
you know, because you do something that gives you such instant feedback and such surprising results.
Yes.
It's just extraordinary, and a lot of things you didn't expect. Really, it helped that. Amazing.
Kind of on that, Carol, is there stuff that you've found, in the last, let's say, year, that has been surprising to you, that's maybe made you think differently about certain conditions or think differently about the body a little bit?
Probably the vagus,
Mhm.
and the most challenging things to treat are autoimmune conditions like MS and
Yeah.
ALS. I can't put tissue back that's not there.
Right.
So I can't put tissue back that's not there. If the patient has done the work, they've gotten off of gluten, they've gotten off of milk, they've done the psychological work that keeps re-traumatizing their brain.
Yeah.
And if the patient's already done that work, we can slow or stop the progression and we can return some function. So somebody that comes in a full wheelchair and he's got some use of his left hand, almost no use of his right hand, and we put his fingers around a grip meter and have him squeeze as hard as he can, and he gets 5 pounds. And you treat to increase secretions in MS or ALS, and the grip strength goes from 5 pounds to 14 pounds. That's not possible. Now, it doesn't last, but when he comes
Right.
back in, he's at 9 pounds, not 14, not 5, he's at 9. So some of it lasts. And so the other thing is you have to accept, that's the hard part for FSM, teaches humility, I'm afraid.
Mhm.
You have to accept that there are some things you just can't fix. You can't put
Yeah.
tissue back that's not there. If somebody has lost their optic nerve because of MS, they've lost their optic nerve.
Mhm.
I can't do that. And that has to be okay. I think you end up getting philosophical. I think the next book, it's called Resonance Recoveries, but it's looking at the process of recovery. So at
Mhm.
first, they're really happy because you made them all better. Yay. Then, someplace between 5 minutes and 2 days later, they're pissed. They're angry. And they're
Mhm.
angry because doctors told them there wasn't any help. Doctors told them it was in their head. Doctors told them that you just have to learn to live with it. Doctors had them with psych evals and they went through really painful or unproductive treatments. So they get
Mhm.
angry at all that. And then they kind of work through that. And then they move into just a period of grief for all that they've lost and all that they've suffered. And it wasn't fair and all of that. And you get to be a guide, a helper, observer. And the only way I can make sense of it and keep my sanity is let them have that emotion. I don't want to treat it. I don't want to get rid of it. It's part of the process. Is to tell them, well, okay, I get that. You were entitled to be angry, and you really are entitled to feel grief over what you lost. But what did you gain? And they look at you like you're stupid. What do you mean, what did I gain? It's like, well, you found out that the world's not going to come to an end if you don't take out the trash. Oh, and you found compassion that you didn't have before. How do you look at a guy in a wheelchair now? Oh, yeah, that's different. How do you look at somebody that walks with a cane, somebody that can't talk? How do you look at that? Did this teach you compassion? Yeah. Is there any other way, as uncomfortable, inconvenient as it was, is there any other way that you would have learned that thing? Oh, okay. So compassion, and you learn that the world isn't going to come to an end if you don't take out the trash on Thursday night.
Yeah.
They'll be back next week. And so you learn patience with yourself. Well, that means you learn patience with other people. And there are certain lessons that we learn by being injured, and the process of recovery is a process, right? It's just, I finally found the title and the content for the next book. That's going to be fun.
And it's beautiful that you're doing that. And I think that's probably the most important conversation, because I'm glad that I'm not the only one who's had that experience where you take that thing away from them that in a very real way has become their life, become their identity. And you have to sit with them through the phases of grief and sadness and anger and all of these things. And it's this beautiful gift we have been given with FSM, but it's also the what do you do after kind of thing, and allowing people to go through that. And I've gotten at times very philosophical about all of it, with folks. And you're right. Like, so you get so many gifts from having to go through some of these harder things in life. And we've all been through them personally. And I think, especially as clinicians, oftentimes the universe tells us we have to go through X, Y, and Z so that we can help the other people going through the same things or similar things. And that's an interesting thing to do, but it's also a beautiful thing because we can actually give people their lives back in a meaningful way. And I'm just so fortunate to have this tool.
I'm so glad. It makes the whole thing worthwhile. It makes the last 30 years seems like the blink of an eye. And when I see the next generation of people like you who are thoughtful and use it in practice and learn from it and develop compassion and a spirit of helpfulness for their patients, and it spreads. You're more patient with your friends. You're more understanding friends, with your partner, with your family, whatever. It creates a mindset that changes the world. It makes it really fun.
Oh, it does. And given that it's been sort of 30 years you've been at it, what are you excited for the next 30 years?
Well, if you listen to Kevin, who is the marketing director for Frequency Specific Seminars, I'm not allowed to die, ever. So Zombie Carol is supposed to be teaching, but
Okay.
I am resigned to the fact that nobody else can teach the core seminar. You can teach parts of it, you can teach the material, but there's just too much that's gone into building it. So we'll build a video. We have a video library. We got the website redesigned so that it's easier to use. So there'll be the course on video, and then practicum instructors. I've got probably 50 around the world who'll teach the practicum. And one of the projects for the next year or two is to get the practicum experience on video, close up, that you don't get in a regular practicum. So get as much of me as on video as we can. Somehow find the motivation and the time to write the second book. And then, I don't know, and then trust the future of FSM to practitioners like you. It's not about selling gadgets. Everybody wants to sell a gadget. So we have, back in 1997, the old blue box was the only microcurrent machine out there. Now that there's some Chinese imposters, Chinese devices, and ours are all US made. But it can't be about the device. It has to be about learning to think. And that's the only way I can do that, is teaching people how to think, and then trusting that the same resonance, if you will, that got me to do it will lead others that are like-minded, open-hearted, open-minded, to follow that path and persist into the future. I think that's the next step.
That's amazing. And I would say if there's any practitioner listening to this who hasn't done a course, please, 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 please just go to a course. And you can thank me later. If you absolutely hate it, I will pay for the course myself, but it has never happened before. And I don't think it ever will happen. So please, I think as clinicians, everyone owes it to themselves to be exposed to this in a meaningful way. And I know you can go to frequencyspecific.com and find all the courses and all the cool stuff that you're up to these days.
And if you're a patient, don't give up. See
Yes,
an FSM
please.
practitioner, and if you don't like that one, find another one.
Right.
And I have had patients who live in an area where there's no practitioner that goes to a physical therapist they trust and says, I am going to pay for you to take this class. You have to take 5 days off of work, and that's too bad. But I will pay for you to take the class because I need somebody to treat me in the middle of Nebraska or someplace. And so patients, don't give up.
Yeah, please, never, never. And there is some level of hardship, I guess, to the human condition, but folks don't need to succumb to suffering.
Good for John. Good. Well said. Well said.
Carol, one last question I sort of ask everyone, and my wife asked this me a couple years ago, and it sort of stuck with me. But if you had 2 minutes and everyone in the world's attention, what would you say?
Oh, that's not fair.
It's a totally not fair question. I
Okay.
recognize that, but
Given that I had 2
you have
minutes.
some beautiful answers.
Great. Frequency specific microcurrent, it has a way of changing tissue and people's lives that makes it worth learning, worth trying, and worth persisting in practice and in the future, to to change the human condition and therefore change the world. I guess that's the thing.
Wonderful. No, that's perfect. Thank you so much.
You're so welcome. Brendan, you've just been a delight to talk to.
Thank you very much. I sincerely appreciate it.